Thank you for letting me present my work today. I'm very excited to describe our efforts in the CASTOP lab to manage non-compressible truncal hemorrhage, which is a major problem and has been considered an intractable problem in trauma care for many years. Non-compressible truncal hemorrhage, or NCTH, is the leading cause of preventable death on the battlefield. It accounts for 2/3 of all pre-hospital deaths due to hemorrhage. And what we've seen is that there are similar mortality rates in civilian trauma as well for NCTH, which makes it a major problem worldwide. It is currently defined as bleeding from within the chest, the abdomen, or the pelvis, and injuries can be blunt in nature or they can be penetrating. There are often several bleed sites that lie deep within the body, and these are very difficult to access. And as a result, we know by definition that manual compression of this bleed is not possible, and therefore the bleed is currently managed in the short term with blood products, intravenous tranexamic acid, and in some very limited cases, mechanical devices such as resuscitative endovascular balloon occlusion of the aorta, or REBOA, can be surgically positioned to buy time or to control bleeding for these patients. And as the only way to really definitively manage NCTH is surgery, the goal of all of these interventions is just to stabilize patients, buy time, and allow them to receive surgery. I also want to acknowledge that as this is such a major problem in pre-hospital, low-resource settings, Norman Bethune undoubtedly encountered this problem many times over the course of his career. Hemostatic agents such as thrombin are currently not effective for managing NCTH, and the reason is that they cannot be locally delivered within the trunk to bleeding sites in order to be able to stop bleeding. And the reason for these are primarily two. The first one is that as the bleed sites are lying deep within the body cavities, it's very difficult to deliver these agents that far. The second is that high volumes of pooled blood within the trunk act as a barrier and flush out any topically applied agents or any agents that are injected. We've developed a novel drug delivery platform at UBC in the CASTOP lab called CounterFlow, which is based on self-propelling particles that can transport hemostatic agents against the flow of and even throughout blood to increase their local delivery into wounds. CounterFlow consists of calcium carbonate microparticles, which are porous and can be absorbed with a wide variety of therapeutic cargo. Calcium carbonate is mixed with a source of protons or an acid, and in our case, we actually use tranexamic acid, which is a powerful antifibrinolytic agent. And when the calcium carbonate and the acid contact blood or any other aqueous solution, a chemical reaction occurs and carbon dioxide is generated, which propels and disperses the particles and the hemostatic cargo deep into wounds. We have previously shown that CounterFlow can be delivered into the abdomen using a minimally invasive procedure that we developed. It is sprayed using a spray device and a catheter. Firstly, ultrasound is used to visualize and localize the site of the bleeding. The catheter can then be placed into the site of the bleed using the standard Seldinger technique, which allows us to achieve percutaneous access without making any major surgical incisions. CounterFlow can then be delivered through the catheters under low pressure into the abdomen, where it can address NCTH. And this whole procedure, including the ultrasound, occurs or requires less than 5 minutes to perform. To verify that once CounterFlow is delivered into the abdomen, it could disperse throughout blood and deliver its cargo, we used the swine model of laparoscopic liver injury. An injury was made and CounterFlow was delivered using the catheter and the minimally invasive procedure that we've developed. And we imaged the inside of the abdomen. What we saw was that CounterFlow was able to spread and disperse throughout the abdomen, which led us to believe that it could be effective for managing NCTH, where there are these high volumes of blood. This procedure, as it's minimally invasive, would be suitable for pre-hospital setting, or perhaps could be used by lesser trained care providers such as advanced medics or physicians that do not have surgical expertise. To build on this, we used the swine model of severe NCTH based on a complete transection of the left lateral lobe of the liver, and we compared the efficacy of CounterFlow to a control group that received only fluid resuscitation with crystalloid solution. We found that CounterFlow significantly increased survival to 3 hours compared to the control group. 40% of animals that received CounterFlow survived to 3 hours, whereas no animals receiving fluid resuscitation survived to 3 hours. And this shows us that CounterFlow is a promising new strategy to manage NCTH, and we are currently working to develop this technology further with our wonderful collaborators at VGH, at the University of Toronto, at the University of Washington, and within the Canadian and the American militaries. That concludes my presentation, and I'd be happy to take any questions that you might have. Thank you for your attention.
Thanks very much, Massimo. Very interesting. Questions?
Is this working? Oh, now it is. Mass, that was great. You there still?
I am, yes.
Hi. I guess it is working. That's fabulous. I had a question in terms of the applicant. You're just disappearing. The application. Have you ever used these in animals that have a disseminated intravascular coagulation sort of phenotype, which you might, by the time you use this, you might see that?
We have not thought to do that at this time. Are you saying that in DIC you would get bleeding within the abdomen?
Situations such as trauma, where the patient might develop DIC for various reasons, whether it be due to the trauma itself or infection, they may have a coagulopathy that's induced, and then as part of that, they have abdominal trauma where they need, your device. So I'm just curious if you've tried to do it in that situation, because you're taking healthy animals who have no coagulopathy at all and traumatizing them, and then using you're applying your technology.
Yeah, I think that's a great question. Undoubtedly, it would be a lot more challenging if we were to do this in animals that had maybe other pathologies such as DIC or maybe other complications from trauma. But I think at this early stage, what we really were focusing on was taking healthy animals, making an injury, and just trying to ascertain that CounterFlow is able to extend survival. And I think in the real world, the application of this would be a lot more challenging because trauma patients have a lot of different problems in addition to the initial bleed. And I think that we're probably going to need to do a lot more work in order to figure out where it's most effective and what the potential contraindications of this technology might be.
Thank you. I had a slightly different question than Ed. You're putting in something that has got generalized hemostatic properties. And I guess the question is, are you able to localize its activity to exactly where you want it, or will it get disseminated into the rest of the coagulation system and generate some other problems?
Yeah, that's a great question. I think we are not able to localize it exactly to where we want it. I guess the overarching goal of the technology is to be able to deliver it into sites of hemorrhage in perhaps something between a targeted and a non-targeted manner, because while we are delivering it into the abdomen, we're not delivering it right at the site of the bleed. And the goal is to try and get as much of the thrombin and the tranexamic acid dispersed to the bleed site, but we have ultimately no control over where the other thrombin and TXA that doesn't get to the injury site ends up. And so I think that is something that we're going to need to take a look at in the future, looking at the potential for counterflow to cause maybe any kind of systemic effects due to absorption from the peritoneal space. But I think at the moment what we're trying to do is to try and get a high percentage of counterflow and thrombin and TXA delivered to the injury site in perhaps a non-specific manner. Yeah, so there is potential for activation of other coagulation factors, also because of the CO2 and all the bubbles that we're generating, which are probably surfaces for these proteins to localize on. But I think that right now the goal is to deliver it into the abdomen, let as much of the particles disperse to the injury site as possible. But no, we do not have any way to specifically localize the activity. It's kind of just like a try and hit the abdomen and try and see what you can get out of it.
Hi, Massimo. It's Prysdale here. Wonderful talk, really cool technology. We've had this discussion already. I'm wondering whether you've considered using this to deliver TPA to difficult to lyse mature clots.
Hi, Ed. We have actually. I don't know if you mean this particular technology with the device, or if you mean just the particles themselves. We have talked about using CounterFlow to deliver TPA to lyse hard to very highly resistant clots, but we haven't actually taken that very far at the moment. I think the major drawback is the lumen of the catheter needs to be a certain size, and then with the calcium carbonate, it's kind of challenging to deliver calcium carbonate through a catheter of that size. So we're going to keep thinking about it. It's definitely an exciting idea. Yeah.
Thank you.